Okay, we are recording. Okay, Mark. All right, welcome, North Carolina. My name is Robbie Fuquay, and I will be your host today for our guest speaker who is speaking on case management and treatment options. We are presenting Marc Lefkowicz, which I'm very happy, firstly, to have Mark back speaking on case management and treatment options. I'm going to give him a formal introduction here in a second. But before I do that, of course, I want to do our quick training update, let you guys know what's happening in North Carolina. I would like to thank the Department of Health and Human Services for North Carolina, Amanda Winters, the program administrator. And this is the last, I guess, webinar that we're doing of the year, and we're closing it out the right way with Mark speaking today. But thank you, Amanda, for you know what, I've got to say, I've enjoyed working with you this year, and I look so forward to working with you next year. And thank you for the great training opportunities you allow us to feed or provide the great state of North Carolina. I also want to thank and our collaborator, the University of North Carolina, the School of Social Work, who's kind of, I call him my training partner. Thank you, the School of Social Work, Jamesia, and Tara, and everyone else behind the scenes that have not only helped and that I've partnered with on these, or that we partner with on these webinars, but the Sure Bet series. And that's where I'm going with next here. I want to tell you a little bit about what's going on with Sure Bet, but thank you, UNC, as well, and Amanda at the Department of Health and Human Services. So Sure Bets 1 and 2, I am finishing the third installment of the online version of Sure Bet 2 this week. It's been a great ride. We've done 3 installments online. I feel more of a sense of accomplishment doing it online than I do face-to-face. I tell you, and I always say this, but I was so nervous this summer getting ready for this, working with the School of Social Work there at the University of North Carolina to make sure that we were able to provide this to you online, and knock on wood, but we have one more week to go and our third installment will be done. So we have done 3 installments of Sure Bet 1 online. In fact, it's gone so well. I mean, we're still working out the kinks with these things, but I will tell you, we're going to start. I will say that we're going to be offering this next year. In fact, we're looking at dates in March and April for our next online versions, but we're going to keep this product to complement the in-person trainings. We're also getting Sure Bet 3, Problem Gambling, Gaming, and the College Experience down in the books. Allison Drain and I put together this curriculum for actually problem gambling and gaming on college campuses. And then we also have another guest speaker, David Wyrick. He's the founder of the Institute to Promote Athlete Health and Wellness out of Greensboro, North Carolina, a local talent. He's done a whole lot in this area, and I believe he talks on prevention and sports betting and all types of betting and gambling on college campuses. So I look forward to doing that. I think we're going to do 3 installments starting in March, maybe late February, but check the Springboard website, the UNC Behavioral Health website, where you've registered for this webinar for more details. It might already be in the books, but I do know we had a conference call last week to make sure that everything's set, and we've got additional webinars coming your way. January 14th, 2021, from UCLA, we have Dr. Rory Reed, who's going to be speaking on stress coping strategies. I actually heard Dr. Reed speak a little bit on this at the California Council, where I also saw our speaker who's going to speak today speak. It's a great talk. So that's January 14th. And then on January 21st, we have Dr. John Grant from the University of Chicago speaking on evidence-based treatment. So that's what's coming your way. And before I turn it over to Mark, I just want to go over our quick logistics. You get a CEU, of course, after successful completing this this hour on what Mark is going to speak about on case management and treatment options. The slides will be available to you after the call, and I'm also recording this, which will also be available to you. In order to get your CEU, you must have registered through, of course, the website and be on the Zoom platform so that you can have the complete impactful learning experience of today, because believe me, Mark always has great things to say, which leads me to, I'm going to give him his due here, his complete, if I can roll out the red carpet for Marc Lefkowicz. He's a certified gambling counselor for over 20 years. He spent over 15 years working for the California Council on Problem Gambling as their lead trainer, facilitating 30-hour gambling certification training as well as presentations on other problem gambling subjects. He received a 25-year award for continuous service on the council's board of directors. Marc also worked for UCLA. The gambling studies program there and was part of a team training therapists to treat problem gamblers and their families. He's also helped in developing a state-funded gambling inpatient treatment program and an intensive outpatient treatment program. He was outreach coordinator for California's free gambling treatment programs. He's taught as an adjunct instructor in 2 community colleges, teaching the required materials for gambling counselor certification. Marc was the program director for one of the few dedicated inpatient programs in the nation in Prescott, Arizona. And as director, he managed staff, created program content, and worked with each individual client. He is currently a consultant in developing residential and outpatient gambling programs. I've heard Marc speak on that as well. So he knows his stuff. Marc has extensive knowledge in responsible gaming, creating and facilitating training programs in over 50 casinos and has trained over 100,000 casino employees. Marc's a national speaker facilitating problem gambling trainings and workshops on topics including financial recovery, treatment, case management, Gamblers Anonymous, and responsible gaming. He has presented in numerous National Council on Problem Gambling conferences. In 2012, Marc received California's Lifetime Achievement Award for working with problem gamblers and their families. Personally, he is a recovering gambler with over 37 years of recovery and has extensive knowledge of 12-step programs. I tell you what, Marc, I've done my job just reading that, man. What a great bio. And I got to say, I consider Marc a friend as well. I enjoy working with you and hearing to what you have to say. I haven't heard this one yet, but I look forward to that, or to it, hearing it. And with that, I'll let you have your space here, sir.
Thanks so much, Robbie. And I'm going to send you the short version of my bio the next time.
All right, man.
Appreciate it. And sorry about my comments earlier on. Get that out of your mind for those people I could see who answered in the chat. So welcome. I'm very grateful and honored to be working here at the University of North Carolina and be able to tell you a little about what I know. This is case management treatment options. I'm going to sort of do it the other way around. We'll start with treatment options and go to case management. My email is up there, marc@kindbridge.com. There are some forms at the end that if you email me, I'll send you the forms. I'll go over that in a little while. So let's start with treatment options. Okay, let's just get this thing going. Okay, treatment options. So I've been working a lot, like I say, in the field. Robbie talked a lot about my experience with outpatient, inpatient, and IOPs. So let me give you a little about what I understand. Some of this might be specific to a certain state of some of the requirements that I'm going to put up, but it's fairly universal. So the ones I'm going to be talking about here are for levels of care or either outpatient, intensive outpatient program, which is like an IOP. 12-step programs is another form of treatment, and they're sort of the original form of treatment. I did that workshop last time. Post-residential treatment or partial hospitalization, and I'll explain the difference between those. Post-residential treatment after getting out of treatment, and there's certainly probably more hybrids than anything else, and I'll explain how that works. And then some people just go with either recovery or life coach. The ones that, I put an asterisk, an IOP, GA, post-residential or residential requires an abstinence-based model. The other ones do not necessarily. So let's just get through them as we, one at a time. 12-step programs, again, this was, there was no formal treatment for gambling until 1972 when in Brecksville, the VA created with Dr. Robert Custer. Great book if you want to learn more about it, When Luck Runs Out. He sort of is the father of some kind of more organized gambling treatment and very instrumental in being one of the major architects of getting pathological gambling into the DSM-3 in 1980. but he also was extremely supportive of Gamblers Anonymous. Actually, one of our first pieces of literature has a lot of work on what he did. So there, for 12-step programs for gambling, there's Gamblers Anonymous, there's Gam-Anon, which would be for family members similar to Al-Anon. But then there's also SMART or Rational Recovery, which is more or less possibly a harm reduction model at times, and not a spiritual program as GA or Gam-Anon. And then going more in a religious way, Celebrate Recovery, which is a Christian-based 12-step program, self-support, abstinence-based model, generally their treatment program. And I love it, for me personally, that's the one one of the concurring ones that I went through is a 12-step based recovery plan. And again, GA is more the spiritual involvement, Rational Recovery less, Celebrate Recovery probably a little bit more. They're free. I'll talk about case management. Case management is informally executed by a sponsor, which sometimes works out, sometimes doesn't. I learned early on the difference between a sponsor and a therapist. The easiest way to understand it is a therapist asks and a sponsor tells. But sometimes those lines are blurred on the sponsor side. At GA, one good thing about most 12-step programs, they have financial recovery components. And even if you're going through more traditional clinical-based, even using some of Gamblers Anonymous or Debtors Anonymous, their financial recovery components actually are really tried and true. So let's go with an outpatient model. It's an individual session, usually done in an office with a licensed therapist or licensed addiction counselor. And these are people treating on alone. I try to find all the different letters in North Carolina. Those are usually people with a PhD in LMFT, LCSW, licensed clinical mental health counselor or LCAS. I'm sure there's alcohol and substance and licensed counselor in those last little letters. Gambling certification training is a plus if you're working with gambling. And I'm sure Robbie has talked a lot about the ICGC, which is an internationally certified gambling counselor. There's level 1, level 2. Level 2 sort of assumes that you've worked, I think, either 1,500 or 2,000 hours and taken some additional training. So, standalone, usually the gambling certification is not enough for outpatient. Generally, a standalone would be in an agency, and I'll talk about that. Amount of sessions vary. They're generally once a week. There is almost always, because these are licensed people, treatment for co-occurring disorders. Gamblers almost always have some kind of co-occurring disorder, generally mood disorders, depression, anxiety, bipolar, ADHD, and certainly the next bullet point, family involvement. I always think that sometimes LMFTs, licensed marriage and family therapists, tend to do real well. What we understand about gamblers affect more individuals than substance abuse because of the way of lying and the fact that family members can't understand the significance of a problem and think they could fix it easier than they could fix a substance abuse problem, and usually with disastrous results. These are people with an optimal level of functioning. They're going to work during the day, they're providing for their family, they're earning a living, and they need this extra advice. They need this extra treatment. It's not necessarily a abstinence-based model. A lot of times they'll, you have to meet the patients where you're at in an outpatient setting. So, sometimes you might have to try a harm reduction model because that's the only way they're going to see you. Generally, the harm reduction models through a contract. Say, you would say sort of, okay, so what do you think is reasonable amount of gambling? Create a contract. And generally, if the person really has a problem, they realize they can't meet their contract and then tend to go to an abstinence-based model. Change, we talk a lot about, one of the big treatment strategies in gambling for treating gamblers is motivational interviewing. And there's more ambivalence probably in gambling than anything else, because gambling is the only addiction that has sort of this false sense, okay, I can win. So it's a matter of really doing some good MI work to bring the person to get them to an abstinence-based model, a lot of relapse prevention strengthening, and in many cases, the therapist can act as a case manager. Intensive outpatient. So, and again, I'm trying to set this up so like you go through levels of care. You try GA, right? Or a 12-step program, it's not working. Then you would more or less go and try outpatient, seeing somebody once a week. But then that's not enough. And sort of some of the bullet points here, I've taken off of like sometimes what insurance requires in order, and generally IOPs, intensive outpatient programs, are insurance-based. It can be either sober living or outpatient. What do I mean by sober living? Sometimes the patients will live off-site. They're working. They're in a sober environment. There's a manager in the house, but it's not like residential or partial hospitalization. And generally, the IOP model is 3 hours a day, 3 days a week, usually 6 to 3 months. The program will have a clinical director, so there's somebody with a license, and they're considered like an agency. So then you could have like non-licensed counselors work under their umbrella of the clinical director. Usually they're called behavioral health techs or BHTs. So they're working under that umbrella, so they can do group work, they could do case management work, and things similar to that. And we'll talk about that when we get into the case management session. There's usually weekly individual sessions with a therapist or counselor. Sometimes there might be multiple, but most of it is group therapy. And the groups could be either process, psychoeducation, relapse prevention, peer groups, etc. And many times you don't need a license to do the groups because you're working under the clinical license. We try and get family involvement in there. Sometimes there might be a weekly group with the families alone, or the families with the gambler. Case management. So they're going through, and we'll explain more about case management. I always put in there notes with a lot of explanation points. If it's not written down, it didn't happen. So generally there are extensive notes. I mean, you can get better at it. It took me a while to get better at it, me personally. Generally notes might be a master treatment plan, a master treatment plan update, progress notes, case management notes. And generally, in most cases, IOPs recommend concurrent 12-step because the person is not bound by the institution. Partial hospitalization, that would probably be the next level up. These are people who are going to be living in, it'd be like sort of a 24/7 environment, but a much looser one than the next one that I'm going to talk about, which is residential. So always, although gambling has maybe, statistics say somewhere between maybe a 25% co-occurring with substance abuse. Sometimes, I'm going to say based on my experience, and this is anecdotal, maybe 1 out of 5% of those people that present for a PHP program, which is probably the most common program, might have to go through detox before coming into the program. Housing is off-site of treatment facilities, so there might be these group homes or apartments. They're managed 24/7, but therapy cannot be done in the residence. All residents will come on site to do the treatment, the group. So usually they, if you see a lot of vans rolling around town, generally that's what's bringing them back and forth from their housing to the treatment center. They also have a clinical director. Again, very similar to, there's non-licensed counselors that work under the umbrella of the clinical director. They generally are doing 5 to 6 hours per day, and it's usually 5 days per week. Weekends are much looser. They might get credit for cleaning the house, doing peer groups during the weekend or doing echo therapy outside. Usually those programs go from 30 to 90 days. Now, in this case, again, for insurance, they're required to see a physician once a week. And what we're trying to do is these people have more acute symptoms. They couldn't do it with GA. They couldn't do it with an outpatient. They couldn't do it with an IP, with an IOP. But they're not at the point they could still function. So we want to keep them in that position so then we can step them down. And generally, almost always, there's either co-occurring medical or mental issues. I would say at least 75%. There was a statistic that said that 75% of people at inpatient meet the criteria who are in gambling inpatient meet the criteria for major depression. So we'll always have that. There might be other issues like diabetes and other things like that. And again, sometimes that could be a tricky situation in a PHP, and it's taken on a one by one basis of how severe the medical, of whether or not it could be handled within the confines of the PHP program. And again, weekly individual sessions, mostly group sessions. Again, they're addressing denial triggers, relapse prevention risks, and financial recovery. There's almost always family involvement. Weekly calls with the family. Some programs might have family weekend, which if you're working for a PHP or a residential program with a family weekend is probably the most interesting thing that I've ever been involved with. Generally, because they're there all the time, you have to find other activities. And other activities might include yoga, equine therapy, ecotherapy, maybe nutrition. Again, you have a case manager, the case management. So these people are living away from home. So the case management is really important to help them mitigate problems that when they come back, those problems will always current 12-step. Again, it's another, when the world is right, it's another one of those vans taking people to meetings all the time. And again, notes. Residential treatment, again, now this is more of like a hospitalization setting. So everything is done within the same unit. Detox, again, consideration. It's an on-site treatment. They live at the facility, they eat at the facility, and they do their treatment at the facility. Again, a clinical director, again, just like the others, non-licensed counselors work under the umbrella. They're generally doing 8 hours a day, 30 to 90 days, must see a physician at least once a week. And here's like one of the important parts is the 24/7 nursing. So now here you could take somebody for sure with diabetes or other problems because they're being constantly monitored and there's something always available in case there are more medical problems. Again, they're dealing with more post-acute withdrawal symptoms, definitely co-occurring medical and mental issues. They're in there because, and I'll go over some of the reasons for inpatient in a couple of slides coming up, but they're going to have much more complex psychosocial stressors. They might be living in a really tough home environment. They just can't stop. They have really poor impulse control, and they need to be monitored 24/7. Again, a very similar kind of family involvement. You want to then titrate down in care. So you're trying to get them into maybe a PHP or into an IOP. And insurance companies now love to try and speed the process because obviously they're going to be paying more money on a residential treatment program. But insurance companies also are very cognizant that wait for the person to be ready. They're, again, addressing denial and triggers, medical medication stabilizing, and based on my experience, there's a high correlation with patients on meds in either a PHP setting or certainly in a residential treatment center where the meds are being managed, and of course, notes. So, what are the goals when somebody gets into an inpatient program? Number one, like I say, it's an abstinence-based model, help the patient stop gambling. provide a safe environment for assessment and treatment, whereas through either outpatient, maybe an IOP, 12-step, that's not there, to provide a comprehensive psychosocial assessment to find the most efficacious treatment recommendations. There's no cookie cutter. There are so many different pathways for gamblers to come into treatment. And we'll talk a little about the biosocial in a slide coming up, to provide comprehensive treatment planning and intervention and continuing care recommendations. Again, I'm going to go over at the very end of this class of how to do continuing care recommendations. Again, the therapeutic process, probably even from every level, even from the sponsor to the counselor to the therapist, the therapeutic relationship is really important, enhancing motivation and decreasing ambivalence in achieving and maintaining mutually defined treatment goals. I usually don't read too much off the slides, but I think these are important. This was written, help the patient cope with the impulse, especially, they're not going to be able to, it's very difficult for them to gamble while they're in, and then to help them learn how to deal with cravings, urges, and the obsession to gamble and not give into it, and to make it more of a positive experience. To improve the understanding of the etiology, progress, and prevention of problem, pathological gambling, and the recovery process. When I worked in treatment, I always did presentations on understanding problem gambling, and also working. We usually do a lot of family of origin work and see where it comes. Just based on my experience, there's some general pathways. Sometimes you'll find your older patients that are coming in, generally with childhood trauma. They were resilient. They got through it. They got involved with their family. They got involved with work. And then later on in life, maybe they're empty nesters, maybe a death, a divorce. The trauma comes back. They don't even know it. It's 50 years old, and they go sit in front of a slot machine and things go away. Or a lot of times we'll find with males who come in at a younger age, sometimes the fallen hero syndrome, or very successful dad, and they want to catch up and they think money is the way to do it. Again, providing education on relapse phenomena, like what are the risk factors, and really work, they have much more time in inpatient to help really identify triggers and warning signs, and to do scenarios on how to avoid them or how to let them go through. Maximize level of function. I always say the most important thing is decrease, my philosophy behind treatment is decrease stress, increase coping skills. Again, rational thinking and problem solving. A lot of that has to do with cognitive behavioral therapy, their interpersonal relationships and skills. Again, that coping, and then stress and affect management. And probably one of the most important things, I'm actually working with a client right now, is, what am I going to do now that I'm not gambling? My job, a lot of times they have jobs that might have, that make it really difficult for them to stop gambling when they go back home. So maybe changing vocation, going back to school. And probably one of the most difficult is to find healthy leisure skills. If we understand the process, the way, if we're using the brain disease model, they stop doing the things they used to do because they're not getting enough dopamine out of it, and to sort of get them back and identify pleasant activities, and to get them to do that. We try and get them to push out the gambling and replace it with more healthy activities. Increase the capacity for honesty. Gamblers are probably the biggest liars on the planet. They're good at it, and to gamble, sometimes that's an asset. Their ability to recognize and live in reality, instead of going straight into escape or fantasy, to recognize unhealthy behaviors and their role in keeping them going, to identify and enhance individually spiritual supports by clarifying values, beliefs. A lot of that goes into cognitive behavioral therapy, to facilitate understanding of the nature of treatment in self-help groups. decrease shame, isolation, and especially, I found that group therapy, that's why I like sort of inpatient group therapy, is probably one of the most efficacious ways of getting gamblers to decrease that shame, like that they know they're not alone. Again, you'll find a lot of omnipotence and ego-based thinking, and to develop a continuing care and maintenance plan. And I'll go over that, as we get towards the end of the thing. I'll go through most of those little bullet points, and to access, make sure that treatment's going okay with the gambler, with the patient, and their family. So then there's sort of what we call post treatment. So sometimes people might step down out of either a residential or a PHP, partial hospitalization program. And generally that's maintenance. Usually there's an individual session. Usually there's group therapy, again, concurrent 12-step. Sometimes there's either recovery or life coaching or still case management. A lot of these are people that have come out of treatment with other people that have come out of treatment. So there are alumni groups, and those can be very helpful. And again, make sure that they're taking their meds. Then, which is probably is more common than anything else, are hybrid treatment options. You could almost call most substance abuse clients and they'll say, yeah, sure, we'll take, we do gambling, and hopefully, some are do it very well, others, and we'll see why as I get through these bullet points. They're usually substance alcohol treatment facilities. Their attributes are usually similar to residential treatment or PHPs or IOPs. Some common groups, sometimes they'll have a few separate groups for gambling, and then a lot of common groups with substance or alcohol. Hopefully, and this is the important part that would sort of, if you're ever sending somebody, I would always ask, do you have a certified gambling counselor on staff? So hopefully there's at least somebody who understands the gambling. Usually in these, there's shared housing, and which could sometimes cause problems because, the substance abuse clients or substance or alcohol clients want to watch the football games or are playing cards to do it. And then you have a gambler in there, and which could be triggered. So generally, but a lot of times it'll work out where, they'll pretty much do have a blanket policy banning those activities. Here's one of the problems also is usually gamblers have to go to NA or AA meetings because in an inpatient environment, you travel as a group. And sometimes it's more difficult to get them to a GA meeting. And usually, which again could be a negative, is there's a very high substance alcohol ratio to gamblers. Another option is recovery or life coaches. They're usually non-licensed. They can be certified, but they need to know their scope of practice. There's some really good ones out there. This when I took my training for recovery coaching, first thing they told me, not a sponsor, not a therapist, not a counselor, of which I sponsor many people and counsel. So, it's really important. They meet the clients where they are. They help manage day-to-day activities like 12-step attendance, appointments, medical job interviews, mental health therapy, make sure they're getting to their appointments. They help coordinate legal and financial issues. So how do you select the appropriate level of care? For inpatient treatment, again, significant depression, suicidal ideation, plan intention, chemical dependency, certainly, or risk of withdrawal, complications which certainly would lead to residential, marked psychiatric illness, severe they just can't do it on their own, severe impulsivity. They've tried, and again, as I said, they've tried everything else, and that's not working. They have little or no external support system. They're exhausted. They're contemplating crime or other serious dangerous behavior, other areas of impaired functioning. They're unstable. They're in crisis state, homicidal. They're just thinking, I just don't know what to do, and homicidal ideation. And then what are we going to do? How frequent are the treatments? Are there phone sessions? How directive should the therapist be? Is the gambler living in an unhealthy environment or physically in risk of danger? And it's sometimes just like the movies where there is danger from bookies and loan sharks. You know, how much are we going to bring the family in? And will we see the spouse and the gambler together, or should another counselor treat the spouse? Is medication needed? Do they live with somebody else who's an active gambler, drug abuser, alcohol? Is the person exposed to physical or emotional abuse? Those are, and that was adapted from Dr. Richard Rosenthal, who also was was one of the people with Dr. Robert Custer to help get pathological gambling into the DSM. So gambling one, so you're taking history of psychiatric illness, physical illness, history of family, psychiatric illness, physical illness, prior treatment, drug and alcohol abuse, relationship history, legal history, social support, occupational, education, family dynamics, suicide assessment, current mood, brief mental health, mental status examination, religious, spiritual. And again, those are just general that you would do: drug, alcohol, gambling, or other process addictions. I'm just going to go really briefly through gambling specific intake, which in this case, and you'll have the slides so you can go through them. This is generally what I'll do when I'm working with a gambler, especially in an inpatient setting. Find out if there are legal situations. What game did they play? So we find out whether or not it's more of a stimulant or a depressant. When they gambled, which will help us, details of the behavior might help us when we're working with triggers. Their cognitions, certainly, like I say, gamblers tend to have poor cognitions. One thing that separates gambling from everything else is the dream world, motivations for gambling, emotional reactions, factors, degree of pressure from others to quit. And again, you'll have copies of these slides. They're pretty much self-explanatory. Reasons for quitting now, past attempts, really something really important. Why? It's always the first question I almost always ask. Why now? What's bringing you into treatment? And it allows me to use a little bit motivational interviewing to get them more into the action stage. Longest period of time without gambling. So what's worked? Degree of impulsivity, their degree of incorporating identity as a gambler, access to cash, again, gambling triggers, so we work with triggers, their degree of dishonesty, and where they are in the state of change. So if you want to find gambling treatment, again, these slides will be available to you. I want to get into the case management part, but there are state and national helplines, the National Council on Problem Gambling, ncpgambling.org. North Carolina has a Council on Problem Gambling, ncouncilpg.org. There's a national helpline, 800-522-4700. You could do web searches for finding treatment. You'll see that when you look at the slide. State-funded treatment. Many states have free state-funded treatment. Again, you could usually find them by searching for the state problem gambling councils. North Carolina, their website is More Than a Game, artnc.com, and the North Carolina helpline is 877-718-5543. And now there's a lot of new teletherapy options for gambling treatment during the pandemic. I don't think they're going to go away. So let's get into case management. Sort of a definition of case management sort of goes like this. And I'm going to redirect directly off the slide. Case management is a collaborative process. Collaborative, you're working with the client of assessment, planning, facilitation, care, coordination, evaluation, and advocacy for options and services to meet an individual and family's comprehensive health needs through communication and available resources to promote patient safety, quality of care, and cost-effective outcomes. Let me get back into here. So generally qualifications, I took this off one of the companies that I worked for. This was their sort of job description. Again, based on education and experience, applicants should have a minimum of 1 year in a behavioral health setting, must possess good verbal and written communication skills, certainly a must, be able to multitask because they're doing sometimes working so many different things with a particular client and then have multiple clients, work effectively under pressure and in a crisis setting because you want them to take the pressure off the client so the client can focus on their treatment, maintain highest degree of confidentiality, must be clean themselves, pass urine analysis testing, and be willing and flexible to take direction from the patient and maybe from the clinical director. Their duties generally involve performing tasks necessary to scheduling and conducting interviews, maintaining timely documentation pertaining to the assistance given to the client, make sure if applicable, if they have a drug or alcohol problem, that they're getting urine analysis testing on a regular basis. Or sometimes I know even in our gambling, if somebody had a weekend pass, we still always will usually UA them, urinalyze them on Monday when they come back into treatment. Assist immediate supervisor. So sometimes, and we'll see how that goes when we get into the continuing care coverage for, make sure they're coordinating between all departments of treatment, finding necessary resources and service, communicate and coordinate clients clear with regard to outside entities. So make sure when they go home, they might have their job or work on their insurance, their FMLA, which is their work insurance that's allowing them to come into treatment, or legal or other financial issues. Community service, there might be cases where they have to perform community service when they leave. Assist clients with achievement of goals like school or work. So that's basically it. And I want to spend a little time here. This is something that I had put together of a continuing care plan for problem gamblers. If you email me at marc@kindbridge.com, I will send you a copy of this. Feel free to use it. And the continuing care plan is generally the way that I will take, I've done some obviously I've done case management, and this is what the form that over years that I developed, and sure took from all different other kinds of form, and put this together. So generally, in the beginning, I'm going to try and the first thing I do is find out what they need and what their barriers to treatment are. And so the first thing I'll do is assessment of needs barriers, and I'll sit with them and I'll read this to them. I always like reading. I don't have them just sit there and fill things out, because a lot of times when you're doing these things orally, you get to read a lot more into where they're at. So I have a place to live after treatment. So to find out whether or not I'm going to have to figure out housing or a job, while they're in treatment, am I going to help them try and find a job? Insecurity, that's probably one of the most common things in terms of gambling, is that financial insecurity, or they're in great debt. And I'll talk about that for a little minute. That'll be like some of the last couple of slides, and how to help with that. Legal issues, again, really important. And you want to stay probably on top of that more than anything else. Then usually the financial is second. Educational or vocational training. Generally, I always ask a question of spirituality or religion. I've found that, that sometimes there's generally a lot of addicts, and this is anecdotal, that seem to certainly have problems with religion. They might have had very negative experiences in childhood. And, if they're going to go to 12-step meetings, it's going to come up, and then they develop a resentment. So I want to find out where they're at there. With gambling, well, I need to take a bit of physical care of myself. You'll see in many cases, gamblers are not taking care of themselves. Either their health insurance is lapped, they're gambling for long periods of time, they're not getting a lot of sleep, they're eating non-nutritious food, and we sometimes see a lot of diabetes or heart problems associated with people that are coming in for gambling treatment? Do they have a doctor? Do they have a primary medical doctor? Are they seeing a therapist? You know, a lot of people might have been recommended into like sort of inpatient treatment from a therapist. And so we want to make sure, are they seeing a therapist? Are they seeing a gambling specific therapist? Again, that also the case. Is their family seeing a therapist to cope with their gambling problem? Are they going to GA meetings? Are they going to other support groups? Are they doing self-exclusion? Self-exclusion is where you could sign up. In most cases, you could sign up with the casino where you ban yourself from the casino. You sign a piece of paper saying that if I'm caught in the casino, I could be arrested for trespassing. If I hit a jackpot, I won't get the money. Or self-exclusion from internet. There's a lot of internet gambling blocking software that could be put on your phone and computer. Do they have that now? And then I'll generally ask them, are there any other anticipated needs not mentioned? Other things might come up. And then what are the barriers to treatment? What have you tried? I just can't do that. So I know where I'm at. And then I might, you know, where I can, I'll use motivational interviewing to overcome the barriers. So after I get finished with that assessment of needs, now I know basically what I have to work on. And then I'll generally early on, I'll have them fill out recovery goals. And if I can get them to come up with recovery goals through their period of, and most of this goes for like either a PHP or a residential treatment. So I have time with the client, especially even as a case manager, and I'll have them identify short and long-term goals that have, I'm going to read from this, that serve to resolve problems that they've experienced in the past to help their recovery and otherwise help them to achieve a greater sense of balance. Balance is really important for addicts, taking the middle of the road. And again, you know, I try and get them, which is difficult sometimes, to make their short and long-term goals specific, realistic, and obtainable. There's about maybe 15 of them that I'm going to go through that I'll go through right now. And sometimes I might just have them focus on their top 5 so they could do a really good job. So physical, short-term might be, I'm going to, when I leave here, while I'm here, I'll go to the gym, I'll work out, because most inpatient or partial hospitalizations have some kind of gym or health club component. When I leave here, I'm going to continue to join the gym. I'm going to walk, be specific. I'm going to walk 3 miles a day. I'm going to go to the gym 3 times a week, whatnot. I'm going to change my diet, nutrition, be more specific, and always try and get them to be more specific. Emotional. And generally, emotional goals will generally have to do with continued therapy. Sometimes it might be meditation and things like of that nature to sort of get themselves emotionally back together. Financial, again, is generally short-term goals is how am I going to pay it back? And then I'll try and go over those for a couple of minutes of an example of a sheet. Long-term goals would be to start saving, maybe buy that house, buy the car, and again, be specific. Legal, you know, a lot of times this doesn't apply, but when it does, of what they need to do to take care of legal situation right away and what to do from preventing long-term problems. Again, stress management, this could be going to the gym. This could be identifying coping mechanisms. This could be meditation. Employment, you know, I'm going to go back to my job right away. Long-term goals might be that job is not a healthy environment, and I'm going to do something else. What my spiritual goals are in terms of connection, short and long-term. Family goals of reconnection with my family, and then what I plan on in the longer term. And again, if you want, I'll send you this continuing care if you email me. Educational, vocational, and intellectual. And again, pretty self-explanatory in terms of creating short and long-term goals. Social and recreational. Service, how am I going to give back? Especially if they're going to go in the 12-step process, or how am I going to give back to my community? Because in many cases, they've taken from the community, and certainly other, whatever that might be. And a lot of times in these goals, I'll maybe have them focus on some of the most important goals first, and to really do a good job, and then expand out while I'm working with them. Generally, I'll have them do relapse prevention, where they'll identify triggers, usually their top 5 triggers, and what's their plan to attack the trigger. So trigger 1, 2, 3, 4, 5, a relapse plan in case they do relapse, what they're going to do, and be very specific. And be very specific, and what they need to do, which might be, I'm going to call my therapist right away. I'm going to go to a 12-step meeting and identify that I had relapsed, and things like that, or I'm going to have to go to an IOP, or add an extra meeting, or whatever that looks like. So then generally, this is sort of what I tell my clients. This is sort of what I would call the continuing care treatment plan. And this is sort of the prescription that I call it, like sort of the prescription is, I'm a big proponent of concurrent 12-step with clinical treatment. So here, and I'll help them, on the internet, find out where the meetings are, get a meeting schedules of where they live, and so these are the days I'm going to go to meetings. Gamblers Anonymous has a phone meeting, and now this is expanding. And here's the phone number and how to get onto the conference, because a lot of people might not be in places where there are meetings. But what's also interesting now is, because of the pandemic, there's a lot of Zoom meetings. So people do not need to physically go to meetings. They're GA type meetings. And as every workshop, every webinar workshop that I've done, I always make sure people understand gamblersinrecovery.com is a website where you could pretty much get on a Zoom meeting, Gamblers Anonymous type meeting 24/7 throughout the world. Then I'm going to get the names of, again, a lot of programs work in conjunction with 12-step. Then I'm going to get the name of some Gamblers Anonymous contacts with X amount of days of treatment. I've obtained a temporary sponsor while in treatment. I'm going to try and find a sponsor with the next, and we try and get, be really specific in the days, because accountability is really important when working with gamblers. Other meetings that they're going to go to, working the steps. Generally it says having completed steps 1 through, it's usually 3 or 4 with gambling treatment, and that they're going to work all 12 steps within X amount of weeks. Usually they don't meet the goal, but at least they set a goal. Other types of support groups like AA, NA, Al-Anons, Sex and Love Anonymous, SLA, Celebrate Recovery, Codependence Debtors, other groups. And again, we want it to be specific, because I try and get people to understand it's like taking medication, and you follow the plan, you're not going to relapse. I'm going to go to the patient alumni meeting. I'm going to see my current therapist, or have contacted a new therapist. When is that first appointment? Same thing for a gambling specific therapist. I have an appointment after discharge days, or a recovery coach, or a new recovery coach, their name and phone number, and when you're going to contact them. Trauma therapists, in many cases, the same thing, or a psychiatrist, especially if meds are involved, or family therapist. And so we try and get them to put it in paper. They might not have one, so we want to make sure that when they get out, they actually have done the work, and we've done the work with them to get them specific phone numbers and names of people who are credible to treat them, whether it's a family therapist, psychiatrist, etc. I plan to exclude myself, what their self-exclusion plan is from terrestrial casinos, what blocking software they're going to use. Like one of them is, there's gamblock.com, there's gambam.com. They have a plan for financial recovery. I talked about this in my last class about GA pressure relief, credit counseling. There's something called the TrueLink debit card, and check that out on truelinkfinancial.com. It's a really cool debit card that can be controlled by family members, so they could really limit access to how the debit card is used. And then, I'm just going to finish on this. I got about a minute or two in terms of financial recovery worksheets. This is just an example of one of the things that I use. I try and get them to put their expenses down, money for savings and investments, and rent, mortgage, property, home insurance, home repairs and maintenance, auto loan and auto insurance. I try and get them to come up with how much money it's going to cost them each month, their gas, their groceries, their meals, if they're smoking, hair, and this is a snapshot. So we don't need to, it doesn't necessarily need to be super detailed orientated. Other expenses like vacation, their unsecured, how much they're paying each month, in credit card balance, their monthly average, how much are they, their monthly income. So we figure out where all their money is coming in. So we have them list how much money goes out in the previous pages, and then how much is coming in. Write them down, and here's the whole thing, subtract their expenses from their income. And if your income's less than your expenses, you have two choices: reduce your expenses or earn additional. And I'll help them be much more detailed. If their income is greater than their expenses, then they have sort of that freedom, and I don't have to go that way. So some of my references were inpatient treatment goals were adapted from Trimidian, treatment modalities from Dr. Richard Rosenthal, intake evaluations from Eric Geffner, and gambling specific from also Dr. Eric Geffner, and case management from the Case Management Society of America. That's pretty much it. I'm gonna, I think I got like 3 minutes, and I don't know if Robbie wants to take over. I'm looking at the chat now.
Hey, Mark, you have a couple of questions. One was from Sharon earlier. I didn't want to interrupt your role there, sir. She asked, what does withdrawal look like from gambling?
Withdrawal generally, it generally is sleep. I've seen rarely, although it does happen, where I've seen people come in with the shakes, but generally a lot of it has to do with sleep, with really extra, like situational anxiety of going over it, of dread, of nervousness, of certainly irritability. Those are generally it. They might have headaches, stomach problems. There's a whole varying amount of different kinds of withdrawal symptoms from gambling.
Okay. Well, thank you. And I had another question, and I almost interrupted on when you were speaking on barriers. We one of the chats was a gentleman. I believe it was a gentleman. It was John's 12 something, but they asked, how does the treatment affect job security or confidentiality? So perhaps to get more specific, in general, how does treatment in gambling or any type of treatment do you think affect job security or confidentiality?
Okay, so
yep.
So in gambling, and what I'm going to say is anecdotal, from working for a long time in inpatient treatment, a lot of times they'll generally not say specifically that they're going into a program for specifically for gambling. A lot of them still have insurance. They get to keep their job. They know something's gone wrong. There's usually some, what they call FMLA, paperwork of working with insurance, of taking a break from work. But then a lot of times, they're working in family businesses. They've embezzled money from the company. But, here's the interesting thing about gamblers. They tend to be really talented people. Mm. And somehow the companies want to keep them, they know what's going on. Maybe they want to keep them keep them working so they can make restitution on it. So in many cases, they're very aware that they're going in for gambling treatment and they want them to get better, and they'll work with the treatment facilities and hopefully get back somebody, a better employee who they once had, and okay, maybe get back some of their money.
Very good answer. Thank you very much. And thank you for that question, by the way. Good question. And I do want to say, and Mark, if you just have a couple of minutes, I have another question, but I want to thank you. And I want to wish everybody a happy holiday. from this platform we have, because this is our last webinar of the year. So, and thank you for everybody who's joined us for these webinars this year. And we look forward to next year, as in starting January 14th. Go to the UNC Behavioral Health Springboard website to sign up for Dr. Reed's helping problem gamblers cultivate stress coping strategies. Dr. Roy Reed from UCLA on January 14th at noon Eastern Standard Time. So, and thanks again, Mark. Great stuff. We had another question regarding anger and aggression. Yeah, go ahead.
Yeah, I'm looking at it right now, and certainly, yes, you know, I was just coming off the top of my head, certainly anger. And a lot of times that anger might go out against a family member, or aggression, you know, usually create a fight, and then, okay, I'm out of here, and I'm headed straight to the casino. And Dr. Reed is great. I worked with Dr. Reed for UCLA. You guys are in for a really good treat. Probably one of the smartest people I've ever met in this field.
Yeah. Well, thank you, Mark. Hey, listen, I've got a question for you too. And you know, I come from the substance addiction world. I don't mind saying now. I've been doing this for some time starting with BDA and now Morneau Chappelle. But I wanted to ask you about your experiences, Mark, because I know you've been doing this a long time. Your experiences, you talked right away on harm reduction. You know, we work on the Problem Gambling Helpline for North Carolina, and I endorse this. And you might have even been a part of that handbook for the UCLA handbook. We utilize that, and I will tell you, and you know personally, I'm trying to get my practice up and running here as well, where I'm at. I've used it, and I will use it. It's great. But Chapter 2 talks about harm reduction, about treatment goals. What's been your experience with it? Because when I came into the field, I will tell you,
in an outpatient setting, you know, you have to meet the client where they're at.
Right. Okay.
And generally, you know, they're not going to see you if you create an abstinence-based model. So a lot of times when you're seeing somebody on an outpatient, it's not just about gambling. It's about a lot of other things. Am I answering too much? Do I have a second more to go, or?
Oh, no. This one will take a couple seconds. Yeah, we can go as far as you need to.
Okay. Yeah. Generally so, you know, there's a really good book by, I think it's Bob Ladouceur on controlled gambling. Of generally, you know, we'll create, you know, like, okay, what's fair in terms of gambling? You know, what do they think is acceptable? And we find in most cases, you know, next week, you know, when we have that individual session, so how'd it go? Oh, well, maybe this week it went good, but next week, you know what? I lost, ended up hitting the ATM. I couldn't do it. And generally, you know, like a little further on, it'll lead to an abstinence-based model. Yeah. It's sort of I always find it dangerous a little of doing harm reduction in gambling because of the amount of money you could lose in just one session. Yeah. Could be devastated in one poor session.
You know, Mark, that's exactly how I position it. I know in the substance addiction world, it could kill someone. It could kill someone, I think, with gambling as well, just for this very reason. I mean, if they're right there. So I agree. We have to be very careful, but I wanted to hear from your experience with that. So wonderful. Thank you. Any other questions while we have Mark at 3 after the hour? So you've got some thank yous and compliments there, Mark, and we want to thank you and compliment you as well. Thanks for coming on with us and finishing the year off of what a year it has been, right? I don't mind saying I'm ready for 2020 to be in the rear view, but what a training, and I do want to thank UNC's Department of or the School of Social Work and then the Department of Health and Human Services for this great state of North Carolina, because you know, and I have to say Morneau Chappelle, we've had to be flexible in our thinking to provide great trainings like this one that Marc Lefkowicz gave us today. So thank you, Mark, and we look forward to working with you next year too, man. Did I freeze up? Can you hear me?
I hope so, and I really want to thank the University of North Carolina. Yeah, I just really want to thank the University of North Carolina. Maybe one of these years I'll get there in person to do a training, and I wish everybody also a very happy and healthy holidays.
Yeah, that's a perfect way to go out. Thanks, everyone. Thanks, Mark. Talk soon, man.
Bye.
Thank you.